I'd just like to read out the Acknowledgement of Country. RAN's co-members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander peoples of this country, sovereign custodians of country. We acknowledge their continuing presence and their contributions made to the college and the communities we work in. We will respect past elders and communities and continue to live, work and interact in a respectful manner with present and future elders and communities. The RANZCO Reconciliation Action Plan reflects the messages of its First Nations engagement. So today we're really just aiming to cover some features of refractive surgery with the aim to give general ophthalmologists a greater understanding of refractive surgery and even perhaps take on some techniques in order to expand their surgical practice. To start, I would like to thank each of my panel members for being here today and speakers. And I'd like to introduce you to Associate Professor Frank Howes. He is the Director and Principal Surgeon of Eye and Laser Centre Gold Coast. And he's been in Queensland doing cataract surgery and refractive surgery for the last 18 years. He's contributed to the research and introduction of a number of sulcus fixed diffractive and EDOF IOLs, amongst other studies in glaucoma surgery and medicines. He's spoken frequently on these subjects over the years. He was previously in the UK, where while Director of Ophthalmology Services for West Yorkshire, he started the UK-wide 8 centres of refractive surgery for the Boots Company with Professor Emmanuel Rosen. He has contributed the chapters on cataract surgery to the 6 editions of the ophthalmology textbook by Yanoff and Ducker, provided the first textbook chapter on SLT in glaucoma, and continues to review on refractive surgery and glaucoma for a number of peer-reviewed journals. So I'd like to welcome him to the lectern. Thank you, Frank.
Well, good afternoon, everybody. Welcome to your late afternoon session. Thank you, Alison, for the invitation to join you, and it's a great privilege for me to join this illustrious team of yours. You've tasked me with a big deal here to talk about refractive surgery procedures and how they're performed. Every single one of us is a refractive surgeon. We all attempt to reach our patients' visual goal surgically when they ask us. Usually emmetropia with a depth of field, and there are multiple routes to achieve this goal. Multiple surgical procedures are available to us. The scope of procedures varies according to the age and visual status of the person concerned. The success of the procedure is much dependent on the procedure chosen as on the assessment, preparation, patient expectation setting, and the execution of the surgery. As always in ophthalmic surgery, your first chance is your best chance. As time moves on, however, different procedures may be needed for that same person. So to remember, coming out of a past refractive procedure requires as much surgical attention as entering another one. And as a surgeon, we must always strive for 0 error. I said to you that we have lots of procedures available to us, lots and lots of them. And they're all over the place, and we start wondering what on earth we're going to need to do with a patient. But we need to look for all these things. It's attention to detail that makes the difference at the end for the refractive outcome on these patients. I've just shown you all the laser suite procedures or minor ops room procedures. But the same thing applies to the operating theatre. We've got refractive lens exchange, medical lensectomy, ICL, the new posterior chamber, much cheaper ICL from India. We've got the old PRL, which you may see in eyes, which are going to need to come out. We have still got cachets around, not that we're using them much. The old phakic 6 is still around in eyes. You may need to start dealing with these on the taking out and putting in point of view. We've got piggyback lenses. We've got pterygiums that we need to deal with. This is a refractive procedure, and you need to pay attention to the excision of the pterygium. And we've got the lifesaver of the astigmatic keratotomy group, which remains to be very useful for us. With all these in mind, we do have to think about what we're doing and choose the correct procedure for our patients. So I'm going to order these procedures into age group. The young is inappropriate for this discussion tonight, but let's just look at the 20s to 40s who are myopic. Stable myopia, less than 6 diopters, that's my cutoff, not necessarily everybody else's, are good for the excimer laser procedures. But which is assessment dependent and dependent on in principle, the topographic issues. Epithelial corneal thickness, the pterygium of a presence, Salzmann's nodules, trauma, recurrent erosion, diabetes mellitus, keratoconus, herpes simplex, and band keratopathy. You need to manage these things before you move on and decide whether it's appropriate or not. Stable myopia greater than 6 diopters is the domain of the phakic IOL. This gives us spectacularly good results. It's tolerant to minor topographic issues, and it's a reversible item. The ICL was also very good in the less than 6 diopter group, where corneal thinning procedures are contraindicated. The myopic target for this group is slightly plus to fend off myopic progression. The hyperopes are another game, though. Laser ablation is invariably a poor option due to the marked regression associated. However, as long as there's AC space, the ICLs make a great option. The target here is never overcorrection as per myopia, but slight undercorrection. 40s to 50s, this is the gray area. Both laser and phakic IOLs are good. The laser caveat, again, is all the topographic abnormalities that I discussed earlier. ICLs are workable, but close in time to the presbyopia correcting IOLs. So IOLs are okay early on in the hyperopes, but not okay in the myopes due to forced PVD and a retinal detachment risk. From 50s onwards, this is the domain of the IOLs. Both the single vision and presbyopia correcting group depend on the examination and the patient discussion. ICL as a phaking laser is used less often, but perhaps more so as the presbyopia correcting ICL moves into practice. Laser is certainly an option for us, but again, is dependent on the corneal issues as I described. Remember, ICLs can also be used in piggyback form, but the sizing is different. We've looked at these procedures now, but let's see if we can look at how they performed. I can't possibly give you a didactic on all these things, so I invite anybody who's got an interest value to join me in theatre if necessary. But I will pass on to you now some of what I deem essential or critical refractive maneuvers specific to certain procedures and common to so many procedures that either facilitate the procedure or add to the refractive outcome. Very important for the generalist. Smile. I'm going to leave this one out because it's not likely that anybody here has actually got a smile laser, and these instruments are changing all the time. So let's move on to those who maybe don't have a laser room but have a minor ops room. It's not infrequent where we find persistent topographic changes when you're assessing your patient and deciding whether they're suitable for A, B, C, or D. Are these changes epithelial? Are they stromal? And in the absence of slit lamp visible changes or post-dry eye treatment, de-epithelialization, in the absence of very sophisticated technology, gives us access to Bowman's membrane for the view of trauma, infective scars, LASIK flap folds, pterygium remains, Salzmann nodule edges, either for diagnostic purposes or access, because you can peel a Salzmann off very effectively by reaching for this device. And it can push quite high hyperopic changes, so beware of that. Occasionally, immediate topography after you've done this will give you the answer to the irregularity of Bowman's membrane. Following reepithelialization, you can redo your topography and get the answers for the correct refractive surgical procedure to follow, or provide the grounds for information on patient expectation. Now, let's move into the operating theatre. Sill management. Almost every cornea has some sill. Even small sills need management. Two small sills, malaligned, gives potentially one larger sill. And all theatre-related refractive surgical procedures require a corneal incision. On-axis incisions dramatically reduce the likelihood of lost sill. Off-axis incisions create a new sill at 45 degrees to the bisector and can significantly change your pre-op sill management plans, allowing incorrect toric IOL placement. Remember that the corneal cylinder power induction reduction of on-axis incisions is proportional to the width of the incision and the proximity to the visual axis. Remembering, of course, that corneal width is widely variable. So same length incisions have different effects at different white to whites. Plus, of course, there's the unknown variable of hysteresis and corneal thickness. The effect of these decisions can be doubled by making a similar incision on the 180 degree on the opposite side, the so-called OCCI, and many of the microscopes will provide that for us. You can find references to this in my chapters on cataract surgery in the Janov and Duca textbook. Now let's talk a little bit about presbyopia correcting IOLs. Just a few brief comments to make. This has created a whole new dimension in refractive surgery, and it's placed additional new demands on surgical accuracy to provide our patients with optimal refractive outcome. And the attention to detail and zero error provides this. The surgical technological advances are helping us provide this. For example, here is an overlay for exercise in a pupil with, that is slightly eccentric and maybe a smaller white to white. Here's for an example of a larger white to white. And remember, when you're zoomed in a microscope, you lose the scale of relativity and hence the value of this to maintain optic coverage for your intraocular lenses. It will also provide you with the astigmatic alignment, but also Purkinje image 1 and Purkinje image 4, which you can align inside your inner rexus circle, which I keep there just for that purpose. And if you have a look at this, that will always not gift you with a central picture, because the capsular bag is not necessarily concentric to the limbus. And you will see in this picture on the screen that the divide and conquer lines are eccentric, just demonstrating displacement of this bag. And so you will not always get this kind of alignment. At this last picture now, I just want to remind you that even the spherical IOLs are best aligned horizontally to minimize the chances of negative dysphotopsia. Now, just a few words about RCL. Optimal refraction is required for good outcome, especially the cycloplegic and hyperopia. The white is critical. Reliance not only on automated measurements, but the manual device, Penacam digital caliper. Record all your findings and put it on a graph in your notes. And you can see the crossover points for the different RCL sizes to help you get the right size RCL. This demonstrates what I use in my notes. Obey the on-axis rules to minimize cell induction. It does mean you need to rotate your RCL to the horizontal position, and these patients can do exceedingly well with that and get the very results that we're looking for. Remember, the sulcus is wider vertically. Rotate to this position if the ICL is overvolted and spherical, obviously non-toric. Remember, the PIs in hyperopic ICLs, the penalty for omission here is Uretz Evalier. And manual OVD evacuation is better than automated because the penalty is potentially a macular hole. On that basis, thank you for listening.
Thank you, Frank. I have a question for you. Do you think that with the small incision cataract surgery or refractive lens exchange surgery that we're doing these days, 1.8, 2.2, 2.4 millimeter incisions, that these can be neutral incisions, depending on construction and placement?
I think it's critically important to work on axis all the time. I think once we get below 2, the effect does become very little. However, we can use, there's always a little bit of astigmatism which you can actually turn to your benefit for your IOL insertion. The smallest incision I use is 2.2, and I'm often increasing to 2.6, 3, 3.2 to manage residual sill because it's there. So we may as well fix even the little amounts that are there. Remember that as soon as you go off axis, you start creating other cells that you don't know where they're going, particularly if you're throwing hysteresis and corneal thickness into the mix as well. So I'm very strict, and all my notes go down to the theatre staff with on-axis incision measurements, and I actually use the overlays from the microscope, and they know to put all that data in, and I'm consistently on axis all the time. But yes, I do agree that if you're down to 1.8, if you're using bimanuals, that the effect is obviously going to be much less. But if we've got a means to reduce whatever cell is there, why bother with astigmatically neutral? In other words, retaining what was there before, if that's going to happen, if you can fix what's there.
Thank you. I think we can have some more interesting discussion about that, around that in the later panel discussion. I'd like to introduce now Dr. Abby Tennant. She's a leading refractive surgeon based in Melbourne with long-term experience across a wide variety of techniques and technologies, including femtosecond technology since 2005. Thank you, Abby.
Okay, thank you, Alison. Hi. I'm going to start off by asking why the general ophthalmologist needs to actually know about refractive surgery. And the answer is quite simple. We spend a lot of time and energy preserving and restoring vision. But the truth is, if a patient's eye is out of focus, no matter how healthy you tell them their eye looks, they still think they have a bad eye or bad eyes, and they find it dysfunctional. And in this day and age, patients no longer accept that the only option for them is glasses or contact lenses, and therefore the only option cannot be to go to the optometrist. They want to know about surgery, and increasingly we're finding that patients are self-educating. They're well informed about refractive surgery. Optometrists are increasingly referring refractive surgery cases to us. But unfortunately, ophthalmologists in general don't really spend much time thinking about it. And as you can see by the small number of people in the audience, it's not really a priority, but it needs to be, because patients actually expect more. And I've got news for you: if you're doing cataract surgery in this day and age, you're a refractive surgery surgeon already. Because with all the premium IOLs and the high patient expectations, if you're not getting an excellent refractive result at the end of your surgery, you're going to have an unhappy patient. So it's really important to know what the variety of surgeries are. And if you're not doing the surgeries yourself, at least know where to send patients if they ask you about it. Patients don't like when they see a general ophthalmologist for 5 years, 10 years, and every time they ask about laser, they're just given a flick to say, just go wear your glasses, don't worry about it. And I hear that, I don't know if you guys hear that, but I hear it all the time. I hear it almost every day, and I think it's time for that to change. So who should and who shouldn't get surgery? I'm going to start off by saying, very important take-home message, this is purely an elective space. So if a patient is not asking for refractive surgery, then they're not a candidate. If they are asking for a refractive surgery, our job is not to tell them what they need to have done, it is to assess them and work out what the safe and viable options are for them, and then they need to choose whether or not they go ahead. So if you have a patient who's interested and you've assessed them, these are the main key players in the refractive surgery space. Now, you'll notice as you go through speaker to speaker, everyone's got their own range, and Frank's range is a little bit different to mine, and I'm sure everyone else has got their own. So the ranges can be really subject to surgeon preference. But essentially, with LASIK, which is one of the most commonly done, it's from -10 to +5 with up to 4.5 diopters of SIL. A LASIK patient needs to have a thick enough cornea. The minimum standard is 500 microns. The cornea needs to be regular in shape topography. They need to have a healthy eye. They shouldn't probably have autoimmune disease, so rheumatoid, where you cut a flap and they might melt, probably not a good idea. They shouldn't have had active HSV recently or obviously currently, and probably very dry corneae and not suitable for LASIK because, as you know, you're severing the corneal nerves, which take up to 6 months to recover, so you will probably exacerbate a dry eye for that period of time. So then we look at surface ablation as another alternative, and those surgeries are either PRK, ASLA, or trans-PRK. And trans-PRK is when the excimer laser takes the epithelium off instead of using a manual technique. The range for this is a little bit narrower than LASIK, although some people will do higher PRKs, and I've done -10 PRKs in certain circumstances. And this surgery is really for a patient who's got a thinner cornea, a less regular cornea. The recovery is uncomfortable. It hurts. For 3.5 days, the epithelium is not yet closed, and so pain medication is required. And you have to consider if the patient's perhaps immunosuppressed and the epithelium's open, they may be at a slightly higher risk for infection. So you have to consider, do I do a surface ablation or do I go back to LASIK? These are some of the very obvious inclusion-exclusion criteria, but there are nuances as well, and I don't have time to talk about nuances, but just consider for a moment, if you've got a patient with Tourette's and they've got uncontrolled head movements, then putting them on a LASIK PI and keeping them still without the use of IV sedation is probably going to be impractical and maybe even dangerous. So you have to look at the whole patient, not just the eye and the cornea when you're making the decision. SMILE is very similar to LASIK in terms of suitability criteria. And please remember with laser, just because the patient is out of range doesn't mean they can't have it. So for example, if you have a +10, 20-year-old patient who is dysfunctional and cannot wear glasses and contacts, and they might be too shallow for ICL and you wouldn't do an RLE on a 20-year-old, consider maybe doing a half treatment and eliminating 5 diopters, and then they can wear glasses and contacts that allow them to get on with life in a more functional manner. So sometimes there is a role for thinking a little more creatively around exclusion criteria. ICL you'll hear a lot about today. The range is fixed, and in Australia we have from -18 to +10 and 6 diopters of SIL. But this surgery is really no good for patients who rub their eyes severely. You're going to get chafing of the iris, you're going to get iris touch, you're going to increase the risk of cataract and glaucoma. So the patients need to have enough room in the eye, they shouldn't be eye rubbers, and they shouldn't be potentially too old either. As the crystalline lens enlarges in size, it comes up and narrows the gap between the ICL and the lens, more likely to achieve lens touch and then cataract. So ICL is not a very popular choice after about the age of 45 to 50. And then RLE, which you all know about. But be careful with RLE in the emmetrope. An emmetrope who sees perfectly for distance, who might be 50 years of age, is not going to thank you if you put in a multifocal lens and you reduce their contrast vision, and after the surgery their distance vision is not as good as it used to be. They're also not going to thank you if they have blinding glare and halos at night and they're a truck driver and they can no longer work. So you need to, again, take the whole person into consideration, because you do sometimes see certain doctors will take on a multifocal as their standard and they'll put them into everybody, but you've got to think very carefully on an individual basis with a technology like that. So the common red flags. The common red flags, and again, these are just the basics, not the nuances. Too young, obviously you need an adult. You need an eye that's no longer developing and changing, and so about 19 or 20 is about the youngest age. And too old, well, how old is too old? It's hard to say. If you've got a 65-year-old patient who has no cataract and they don't want to have an intraocular procedure and they've tried monovision in a contact lens and they absolutely love it, why wouldn't you do a monovision LASIK to tie them over? And they can always have a lens exchange or a cataract procedure later on if they wish. So even though surgeons sometimes think you can't do laser on that age group, it's not true. You can. There's a bug. Pregnancy and breastfeeding speaks for itself. Obviously, you don't want to give unnecessary drugs in an elective situation to baby. And also the cornea is unstable during pregnancy and breastfeeding, so your results are not going to be accurate. Active disease, again, speaks for itself. You don't want to laser or put an ICL into someone who's got a rip-roaring inflammation or someone who's rubbing their eyes severely. And you have to qualify, what does eye rubbing mean? If they're just touching the corner, or they give their eye a little rub after taking their contact lens out and it's contact lens related, that's not eye rubbing. Eye rubbing is when they're doing this and they're doing this. So you can't just ask, do you rub your eyes? You need to know how they're rubbing their eyes to work out if it's going to be a significant issue in terms of post-operative complication. Keratoconus is usually a contraindication, but you can do PRK and put ICLs into patients with mild keratoconus. And rapidly changing refraction you need to take into account, because if someone is still changing, you don't want to be chasing a tail and operating again in 6 months to catch up. So roughly 18 months of stability is a good idea. What I think is probably more important than all of the above, though, is emotional state and personality factors. And this is where psychology and psychiatry crosses over a little bit into ophthalmology. And I'll show you an example rather than talk about it because it's easier to show you. So by the time a patient says hello to me, they've gone through several screening processes, and I look at their paperwork and I pretty much know what they're going to be suited to before I even meet them. And one of the things they do is fill out this questionnaire about general health, ophthalmic health, and expectations for surgery. And if you read down this list that the patient has filled in, they're essentially expressing problems in every way. So already I know that the patient either has a lot of problems or is anxious and thinks that they have a lot of problems. And then when this patient came in to see the orthoptist, this was the notes written by the orthoptist. And you can see a lot of worrying concerns here. They're sceptical about laser. They're always dry, no drops help. They've got a corneal specialist, but they don't like the doctor and he wasn't helpful. They've got hay fever and they rub their eyes all the time. They suffer from every type of phenomenon, glare sensitivity, halo, starbursts. They can't tolerate light in any way, shape or form. And the list goes on. They think they have double vision, but we couldn't elicit double vision. Actually, this patient had a perfectly normal clinical examination. But evidently, a lot of anxiety around his eyes and a lot of potentially hypochondriasis-related issues as well. And so I said to him, I told him the truth. The eye rubbing made him borderline in terms of suitability. He was a little thin on the corneal side, but I said to him, listen, you could potentially have laser surgery. However, you've got so many concerns about your eyes. You're so anxious. You're worried about all these things that are happening with contact lenses and glasses. How will you feel if you have a problem after your laser? And I showed him the consent form, which is very complex and detailed. I said, I don't think you're going to be happy, and I think maybe you need to think about this. It's not a great idea, and I'm not going to do the surgery for you, but if you wish, I can send you for another opinion. And he went totally quiet, and he stopped, and then he looked at me, and then he said, you know what, I think you're right. So my point being, it's a little bit of John West philosophy. Sometimes it's the fish you reject that make the fish the best. And I think with refractive surgery, you have to think very carefully about who not to operate on if you want happy patients at the end. Thank you.
Thank you, Abby. I would just like to remind the audience that if you have the app, if you don't have the app, please download it, and if you do, please remember to ask questions through the app so we can cover those off in the panel discussion at the end, Q&A, and also address questions in between each speaker. I think what you've said, Abby, is super important about being able to say no. It's much easier to determine a patient's non-suitability from the eye parameters, but picking the patient based on their personality and or lifestyle. While there are some big personalities in the refractive space, I think we actually become better at reading the personality of our patients in some way, because we've all had months and months of chair time with patients that had a perfect result but just weren't the right personality. So I'd now like to introduce Dean Corbett. Dr. Corbett is a New Zealand surgeon with 25 years experience in the public hospital as a glaucoma subspecialist and cataract surgeon, and consecutive to this, 25 years in the private sector as a refractive vision surgeon. He told me this, and I'm not sure if he's joking, because I can't believe that I think he might be joking about the 25 plus 25.
All together at the same time. So the yin and the yang of looking after patients.
I thought there was something wrong with my eyes, Dean.
Yeah.
Thank you for clarifying that.
Thank you, Alison, for inviting the panel together, and thanks for those of you that are attending, and I hope you can take something out of the session. It's always tricky following Abby, who always gives such concise and clear advice about what we're doing, and I think that was absolutely fantastic. So I've some non-significant disclosures. So it's honest and real expectations from refractive surgery. What are expectations? They're expectations of vision, what their recovery is going to be like, how much pain, what the side effects are, what the longevity of the treatment is going to be like. Expectations can be thought about from the patient's perspective, but also from the surgeon's perspective. So these must be aligned in all the care that we give, but most particularly in refractive surgery or vision correction surgery. And ideally, the patient's expectations should be lower than the surgeon's. And we have this axiom that we live by: under promise and over deliver. Information delivery must also be given in a non-jargon language, so we're all understanding exactly what we're trying to achieve. And I think it's really critical that we understand the concept of what vision is. Vision is not high contrast Snellen visual acuity. It's not being able to read the letters on the bottom of the chart. It's being able to feel as though you're seeing well. What happens when you open your eyes is what vision is. And this is the sort of image that, we'd like people to be able to appreciate. So the patient has some choices to make, and we're there to guide them. And instead of that patient being guiding themselves, we need to be there helping them along what's happening and what their options are. So what are the surgical procedures? It's already been covered to some degree. They're corneal, phakic, IOLs, and lens replacement surgery. So let's talk about the cornea. We're talking about laser vision correction, and that's myopia, hyperopia, with or without astigmatism management. And the reality is that this has an extremely high patient satisfaction, higher than any other surgical procedure that we undertake. That's been documented in literature very clearly on a number of occasions. And, what's the most common reason for patient dissatisfaction? I'm sure you're all thinking it's dry eye. It's not. It's uncorrected refractive error after they've had a procedure. Presbyopia correction with monovision, Abby alluded to, and this is an area that's got better and better over the years with better platforms for treating hyperopia, and I think it's really an area that we undertreat, and presbyopia is that condition that many of our younger colleagues really don't understand how debilitating it can be. And we do have some good management. We use a lot of contact lens simulations to sort those people out in regards to whether we're going to use a corneal procedure to correct them. And there's very high patient satisfaction when you choose the right individual. So what can we expect? Extremely high patient satisfaction, high accuracy, good safety, minimally invasive procedure, and happy patients. Also on the cornea that Frank talked to is management of the astigmatism incisionally, and this is a tool that we can use. There's nomograms available. Frank's told you about his in his publication, and there's a link there that you can look at. And we can expect, good procedure, no harm essentially, a high chance of better uncorrected vision, but no guarantee of effect because it is somewhat variable with the nomograms and the surgical delivery that we use. So I'd like to tell you a little bit about, as an example, really of what we can do with our refractive surgical techniques. So this is a young gentleman. He became my patient after a planned laser procedure delivered fantastic vision in one eye, but in the other eye, not quite so good. And what had happened is that the axis of treatment had been flipped. So instead of reducing astigmatism by 3.5 diopters, it was doubled. So he wound up with a very problematic eye. So we went on to, when I inherited this patient, to perform an implantable Collamer lens to reduce his astigmatism. And then unexpectedly, his astigmatism, despite normal corneal topography, continued to increase post-operatively. So it went from an initial expected 3 diopter still back out to 5. And if we look back at that slide, we can see that the equivalent sphere is approximately 0. So we did have some options. We could go back and retreat him with LASIK. It was initially a high treatment, so his cornea was thin, or we could have done a limbal relaxing incision. It is not ideal because it was the highest limbal relaxing incision that we can do, 90 degrees, and they have to be pretty accurate. But the outcome in the hands of the opportunities that we have in our hands was not too bad. I had to open the cuts of the slit lamp on 2 occasions, and you can see what that looks like here. But with fairly regular LRIs, his outcome was not too bad in the face of a very compromised outcome initially. Phakic IOLs, we've already heard from both Frank and Abby. These are absolutely outstanding devices, particularly the ICL. And we can see the schematics, and in the bottom right picture, an ICL in situ with a nice gap or vault between the crystalline lens and the ICL. And here's an artisan lens, which I put behind the iris, but not in front of the iris, because I think the ICL is a much better alternative. So, It's often reserved for patients which are unable to have laser vision correction. So it's frequently for extreme refractive errors, and because of that, the patient satisfaction is enormously high. When we're treating lower numbers, we still get excellent outcomes, similar to laser vision correction outcomes. So it is a procedure which requires attention to detail, and as Frank's alluded to, one of the most important things is the size of the ICL, so we get an appropriate vault and we don't get the potential for angle closure. But what's changed with this product in the last 7 years is the hole in the middle of the ICL, and that allows for aqueous circulation, and I think really has essentially eliminated a lot of the complications that we have had in the past, in particular much less chance of inducing cataract because we've got circulation of aqueous, even in the presence of a very small vault. So what can you expect? Well, it's high cost, but extremely high safety and efficacy. There is a significant learning curve, and it's an infrequent demand because of the cost, but it's a big tick. So we move to lens replacement surgery. Well, anyone can do that. It's an easy operation with great results, and it's undertaken for a cloudy lens or focus correction or to extend range of vision. Okay, enough of that. It's a minefield. We can stand up here and talk about it all day for 3 weeks and still have questions that we can't answer. These are some, not all of the lenses that I've put in over a period of the years, and we still haven't got one that's really, really good. But it's also an unpredictable and procedure for the patients with irreversible outcomes, and we need some tools. And the tools are, as we see, we've got to have them available to us. And it kind of goes to what Abby said. I think if you haven't got the tools, be sure that you can refer to somebody that has. We need an ocular surface plan. We need a focus enhancement strategy. This is non-negotiable. If we're doing a lens replacement for focus correction or extending depth of focus and we've left the patient uncooked, we must be able to offer them a focus correcting solution. We must be able to exchange an IOL that's not delivering a satisfactory outcome, and the tools for this are outstanding, and I'm sure that all of you are capable of this surgery. And again, feel free to reach out to any of the refractive surgeons who are performing this on a regular basis, and it is something we need to be able to offer patients. And we need to manage vitreous syneresis as a cause for patient dissatisfaction. It's a common problem. It's more in younger patients, so I don't like doing elective lens replacement surgery for patients under 50 at all because of the effect of the vitreous. And it may be debilitating, especially for diffractive IOLs. So summary, it's a minefield of possible outcomes with lens replacement. Don't drop the ball. If somebody passes you the ball, you start the surgery. Don't drop the ball.
Wilson and Smith. Lovely step. Wilson. Yes.
Yeah, that hurt.
A tragedy.
That was a final Bledisloe Cup match for those of you who are mature enough in the audience to remember it. Know the game. Don't be afraid to ask people who are doing this sort of surgery, and don't start until you have all the tools and can access them. So I finish with expectations. It's an excellent procedure with outcomes 90% of the time that will deliver good patient satisfaction. What do you do with the 10%? Well, I think good consent and counselling can sort this out. Here's a guy who had terrible vision and wore glasses but didn't want to. He had a lens replacement surgery and 6.5 N5 unaided OU, both eyes. this is the rest of the team that came along, because this guy here, who was the initial group of 4, had a great outcome as well. All of those people are spectacle-free and will be for the rest of their lives. Thank you. So I'm going to have to dash, so if there's any questions, please sing out.
Thank you so much, Dean. Dean does have to go because of flight issues. I'm sure some of you here have experienced those over the last couple of days. So if there are any questions, please raise your hand and we'll address those now. But otherwise, we'll move on. Thank you so much, Dean. I'd next like to introduce Professor Donald Tan, who we're very excited to have here as our guest speaker. Professor Tan is a senior partner at the Eye and Cornea Surgeons Division of Eye and Retina Surgeons and clinical professor at the Ophthalmology and Visual Sciences Academic Clinical Program at Duke National University of Singapore. A founding doctor and previous medical director of the Singapore National Eye Centre. Professor Tan is a global leader in the field of cornea and external disease and refractive surgery, with major contributions to the development of new techniques and devices in corneal transplantation and corneal refractive surgery. He has published over 430 peer-reviewed articles in the corneal, refractive and myopia fields, and is the recipient of over 30 international awards. He was past president of the US-based Cornea Society and was inducted as a member of the Academia Ophthalmologica Internationalis in 2018. Dr. Tan founded the Asia Cornea Society and the Association of Eye Banks of Asia, and is currently immediate past president and secretary general of ACS. So Dr. Tan today is going to talk about myopia progression, and this is something that is going to increase over time and ties in nicely with us presenting techniques that are available to general ophthalmologists in targeting that epidemic of the future. Thank you, Professor Tan.
Thank you very much, Alison. It's great to be in Australia again after COVID, and I'd like to thank Rangsco firstly for inviting me. It's a bit strange for me to talk about myopia control therapy at a refractive surgery session, but you can rest assured we're going to make it easier for refractive surgeons. So the whole idea about myopia progression control therapy is to reduce the progression by maybe 50% or so. So you don't have to treat your -9, you'll have to treat a -4.5. We might reduce some of our retina colleagues' work. We can reduce high myopia. So I've been asked to give you an update on the treatments for myopia progression, the current evidence, and there's way too much evidence. So I'm going to have to rip through some of these. I do have some financial disclosures. I'm a consultant for some of these companies which are having pharmacological products. I guess I'm going to use this. So here's just a summary slide. Basically, there are three possible treatments today. Some interesting spectacles or contact lenses, and that includes these peripheral defocus soft contact lenses or Ortho-K. But I think the one which has made the most progress over the last 20 years or so has been pharmacological, and there's only one drug here, which is what we're looking at today, which is atropine. So we had a Cochrane review back in 2011, and by that time already they were identifying anti-muscarinic medications, but also the side effects, light sensitivity, loss of accommodation. And at that time, we were already exploring wide ranges of atropine. So I got interested back in 1999, when I think some of you may have been still in school. But we did our first ATOM-1, the atropine for the treatment of myopia. And that was back in 1999. So these are all RCTs, 400 children, 3-year studies, and it was very effective. But 1% atropine causes tremendous glare and loss of accommodation. So we did ATOM-2. Sorry, that slide's meant to be that's meant to be ATOM-2, and we did 3 different concentrations. We lowered it down to 0.5, 0.1, and 0.01. Now, 0.01 was meant to be our pseudo-placebo, but to cut a long story short, 0.01%, 1/100th the concentration of atropine was the best in class. It reduced myopia retardation over a 3-year, or in fact a 5-year period, by 50%, and almost had no pupil dilatation, no loss of accommodation, no loss of near vision, and there was a minimum rebound. To cut a long story short, today, 0.01% is the sort of gold standard. We've just received news in the US, the Nevercar company, which has been doing the CHAMP study in the US, which is an FDA-regulated trial, just announced that the results are very promising after 3 years. So in fact, we might actually get FDA approval of 0.01 atropine quite soon. A lot of these studies, network meta-analyses, they take hundreds of these trials, and basically, to cut a long story short, these are 30 RCTs, 5,000 over children mostly, and the conclusions: atropine works, brenzapine and ortho-K and contact lens, peripherally focused lenses show some effect. Spectacles really didn't, but that was back in 2016. But just gives you an idea. These are forest plots. So on the left here would be refractive change. So anything on towards the right means a positive effect. And on this side, axial length, the less of the axial length elongation, it means a good effect as well. And you can see right on top, the 3 atropines: high dose, moderate, and low dose. Ortho-K is a little bit more below that. So we know that atropine works. They've even done meta-analyses on atropine studies. Here's 19 studies. This was published in 2017, so it's still 5 years ago. Adverse effects are definitely related to atropine, the higher doses, but the efficacy is dose-dependent within the range, whereas it's dose-independent. So what we can say is that you can reduce the concentration without really reducing efficacy, but what you're doing is you're reducing the side effects. Okay, and they did state low-dose atropine would be the way to go. Now, since then, so in Singapore, we launched the 0.01 concentration. It's available in many countries now, but there have been other studies. So this is the LAMP study. This is the other big group in Hong Kong where they started to go higher doses, and they basically went up to 0.025 and up to 0.05. And this was their first study, again in Asian children in Hong Kong, and they showed that their best concentration was in fact not 0.01, but 0.05. And they showed that there was a significant difference. Interestingly, the formulations are different. And if you look at their efficacy, and you look at this is at 1 year, this is the change in spherical equivalent, and here is their LAMP 0.025%. And if you transpose our 0.01%, it's the same effect, both for refractive change as well as for axial elongation. So in other words, the formulations do make a difference, and our atom concentrations seem to be twice as effective. They then came up with their 2-year study, which again showed that 0.05 was better, but they also acknowledged that compared to our atom results, their 0.05 results showed a similar anti-myopic effect to our 0.01 treatment group. So again, as we're deciding how do we go, do we do 0.01 or do we do 0.05, we have to be careful because the concentrations or the formulations will vary. They then did a year 3 study in which they also did a washout. So they stopped the treatment to see whether there would be a rebound. Again, they said 0.05% is the preferred concentration. And when they washed out the groups, they did say that there was a rebound, but the rebound is not really significant, clinically insignificant. But that's 1 year. And if you look at the slope, so if you look on the left here, look at the spherical equivalent, the orange bar is a 0.05. There is quite a sharp drop. And so we do worry about what happens when you stop atropine. After the first year, you might actually get a significant rebound. So at this point of time, we're not really sure what concentration to use. Here's a meta-analysis which just came out this year in ophthalmology in 2022, and they did 16 randomized controlled trials, for 8 different concentrations. So now this is the latest info. So this is what I was asked to show you. It's quite interesting. So the analyses involved 0.01 as the lowest concentration all the way up to 1.0. 0.05 has the highest p-score. So what is a p-score? This is defined as probability of a given treatment being amongst the best. So if you look at the 3 bar charts on the left, this is all the efficacy of refractive change, axial elongation, and overall myopia progression. The taller bars means the probability of having the best result. And you'll see that, I'm not sure whether you can see that, but that's the 0.05 in both axial elongation, overall myopia progression, as well as refractive change. So this told us that 0.05 is the best. But just hold on, if you look and read a little bit further down and you look at the appendix, you come to side effects. Photopic pupil diameter, accommodation amplitude, and distance VA. Remember I told you the smaller bars means the least probability of being the best option. And where is 0.05 here? Here. And here. And here. So it's interesting. This is, I call this publication bias. They were saying that 0.05 is the best. And then somewhere right in the discussion at the end, they did say that there was some issues with pupil diameter. And they produced these charts, but don't really highlight that. So the way I look at this is that, yeah, 0.05 is the best, but it's the worst in terms of side effects. The best study I have seen so far comes from Fiona Stapleton and her group in China. Fiona has been doing this study for quite some time. She went to China and worked with this group, and she randomized 400 kids to 0.01 versus 0.02. Now, we have to be careful because these are children who are going to be using eye drops every day for many years. All right, so we started with 0.01, which is the lowest. We found it's reasonably effective, and if we want to go higher, we can go higher, but in stages. And so 0.02 was analyzed, and they found statistically different significant changes in the spherical equivalent as well as axial length between these groups. So in other words, 0.02% was better than 0.01 in reducing myopia progression. What's more important is they did not see any statistical difference in accommodative amplitude and pupil size. So it would seem that we can go towards a 0.02% without sacrificing pupil issues, accommodation issues, and near vision. All right, so a lot of companies now who have produced 0.01% are now launching 0.02% or 0.025%. Let's not forget what other trials are coming up. So I think the major evidence, and there are probably about 100 clinical trials on atropine ongoing at this point of time. All right, but there are some other interesting studies. These are contact lenses. These are soft contact lenses, dual focus, myopic defocus from Cooper Vision. And it's one study, but they're showing good results at over a 3-year randomized trial, but small numbers. Here's one with a new spectacle, a myopic defocus spectacle from, in this case, Essilor. And they show some interesting results as well. It's a 1-year study. And here is even a red light study. Now, we used to think about light, but some good animal evidence is becoming available now. And this is a randomized controlled trial in Chinese children to show that using a little device in which they look at red light just for about 3 minutes a day seems to work. But again, it's only for 2 years. So I think overall, we need to watch this space. There are lots of things coming up. Where are we today? I think 0.01 is now being accepted as a highly effective and safe approach. What's next, I think, will be ramping up to maybe 0.02, maybe higher. I think we need to have more trials. But then let's not forget some other things like myopia-controlled spectacles and contact lenses, and then alternative approaches in the pipeline. Thank you very much.
Thanks,
you,
Donald.
Professor
Yeah,
Sorry.
can I ask a question, actually?
Please.
I think That was really interesting. One of the biggest issues with kids is digital eye strain, screen overdose. So do these studies control, how do you control for screen time?
Yeah, so a lot of the studies that they have diaries, near work diaries. So the parents are supposed to record how many hours of near work, whether it's computer work or reading versus outdoor activities. In fact, there is a wealth of evidence that outdoor activity is protective. So I think there are reasonably good diaries which they will use these in multivariate analyses to exclude these factors. And that's why Asian children in Australia have much less myopia progression than Asian children in cities in Singapore or Taiwan, because they do a lot more outdoor activities in Australia.
Donald, atropine has got quite a long half-life. Why daily administration? My one question. And the other question is, in the groups that you're involved with, starting age and finishing age?
Most of these ages have been 6 to 12. Okay, we've gone beyond that now, so we can go down to 4. So some of the latest studies look at 4 because we're looking at very early onset myopia, especially in Asian children. In terms of daily dosing, it really started with 1% on a daily dose. The washout effect does take a few days with 1%, but for 0.01% or lower, the washout's a bit faster.
So
But
at
it's
low
empirical.
concentrations, they in 24 hours, it's below effective concentration.
I don't think studies have been done in great detail. However, the so-called rebound effect, where they do a trial for 2 years on every day, then they stop, they get a rebound, it doesn't make clinical sense. In a clinical situation, you would tail it off. And what would you do? You would say, stop doing it every day, do it alternate day, for 3 months and stuff like that. So people are playing around with that, certainly. Thank you.
The studies are up to 12 years of age, but practically speaking, we'll see teenagers who are still progressing. What's the recommendation there?
Well, there's no good evidence beyond 12 simply because it's not been done. I think we have to remember the whole goal of myopia control therapy is to tackle myopia when it is on the upward trend. And generally for Asian eyes especially, it tends to be from the age of 6. For Caucasians, maybe from 7 or 8 or 9, a little bit later. But that's the growth spurt until puberty, and then it slows down. So that's where the main focus has been, because you want to tackle myopia, axial length elongation when it is elongating the most. Having said that, I'm willing to bet it really works in older, teenagers as well. The good thing is that atropine works for milder degrees of myopia. So the question everybody asks us, 90% are in Asian children. What about Caucasians? So the US study is showing it's positive. There's a study in Ireland as well. And I think it'll work better in Caucasians because your amount of myopia progression is not so aggressive. Yeah, atropine doesn't work for the really aggressive high myopes, those children who are 6 years old and -6, it doesn't work as well.
I think that's fascinating, thank you, because, as refractive surgeons here on the panel, if we can stop a child becoming sort of -20 as an adult, then what we have available to fix their vision when they're older, if they're -7, say, it would be much better for them. I'm not going to introduce myself. My name's Alison Chu. Suffice to say that I'm a Sydney-based refractive surgeon. Today I want to talk to you about correcting high refractive errors, and we'll have some tips and controversies. These are my financial disclosures. And I just want to take a short moment to remember Con. This is his first RANSCO, and he would have and should have been here. So what is high refractive error? I would consider high myopia to be greater than -8, high hyperopia to be greater than +3, +4 diopters, and high astigmatism greater than +5 to 6 diopters. And I'll really be considering the astigmatic correction along with the either high myopia or high hyperopia. So let's talk first about how we can ruin the cornea. And we can do this by pushing the boundaries of corneal-based refractive surgeries, which can induce scarring with very high corrections, too high corrections, induce higher order aberrations, and possibly strike patients out for future multifocal IOLs when they are in fact refractive type patients seeking a solution to not wear glasses. We can perform corneal procedures that may affect the cornea in an unpredictable way or adversely, and that can include AK in the wrong hands, which can produce some irregularity to corneas, RK, and inlays, which can cause scarring. So ICLs or phakic IOLs that sit in the ciliary sulcus, we've heard a little bit about already today, and I'm going to expand on this. They're not new. We have over 20 years of data. Interestingly, there are now over 2 million procedures worldwide, but this second million has occurred in the last 3 years, so it really is increasing in popularity, and it's definitely a technique that's available to any cataract surgeon and or refractive surgeon. The advantages described are higher definition vision, and I really think that this comes into play for the higher corrections, even though ICLs can be used for lower corrections as well. It doesn't induce dry eye. There's no touching of the cornea, so there's no risk of ectasia or corneal scarring. It offers UV protection, however, not for the ocular surface, of course, and it's permanent but reversible. And I think a game changer in this space is going to be the Evo Viva, which is the EDOF version, which will be on our shores probably early next year. We've already heard the range of ICL powers that we can correct, plus 10 to minus 18. The SIL steps are in 0.5 and up to 6 diopters. It's FDA approved, but can be used off-label outside these age ranges. But of course, over 60, we're looking at lens-based procedures. The eye needs to be healthy and the patient needs to have a stable refraction. Refraction probably is the biggest barrier for non-refractive ophthalmologists and particularly younger ophthalmologists, because our older colleagues are used to doing this, but unless you're in the refractive space, then not routinely doing refractions. Examination needs to include a gonioscopy, and the angles should be open to either the ciliary body or scleral spur. The anterior chamber depth is what usually strikes people out from being suitable, I find, and this needs to be greater than 2.8 millimetres for myopes measured from the endothelium, and greater than 3 millimetres from the endothelium for hyperopes. And I would say for every ICL patient that I operate on, only one of them, for every 20, only one of them is a hyperope. It's hard for hyperopes to be suitable for this procedure because their eyes are just smaller, their anterior chambers are shallower. The white-to-white measurement, I would recommend using more than one method. We've already touched on this already. The size of the lens, which is determined from the white-to-white measurement, determines the ICL sizing. So if the volt is too high, it's going to compromise the angle. If the volt is too low, then the lens is not going to be rotationally stable. The ciliary sulcus is narrowest horizontally, unlike the white-to-white. So that's why the lens, when we implant it, we only implant it horizontally. Then I use a spec mic for endothelial cell count. So what will you tell your patient? Well, that it's permanent but also reversible. I do it as a bilateral same-day procedure under topical anaesthetic, and I use the Goldman applanation tonometer to get a gauge as to whether I think my patient's going to be suitable or not. If they've got too much blepharospasm, then I'll be separating the two eyes because I know that they'll need a block. The visual recovery is very rapid. It's a bit like LASIK, it's bit blurry, quite blurry after the procedure, but by the time they wake the following morning, it's very clear. They need to stay at the operating theatre for 2 hours after the procedure to have their pressure checked, and this is really crucial. It's normal to have halos and glares, but the dysphotopsias are very different compared to what you might be accustomed to with multifocal IOLs, and the Collamer material is very similar to the refractive index of aqueous, so the dysphotopsias settle very quickly and often disappear completely. And then you'll explain the risks and benefits of any refractive or intraocular procedure, but also focusing on the additional considerations of glaucoma and cataract. And I would say over 10 years of doing this procedure, with careful patient selection, I have zero patients that have developed either cataract or glaucoma. You receive a lens implantation diagram. As I mentioned, it needs to be implanted horizontally, but there is some leeway to implant up to 22 degrees, either clockwise or anti-clockwise. So the implantation sheets will give you the exact axis that you're going to implant that lens.
Can we skip to the good part?
So now I'm just going to go over some surgical steps. to get you familiarised with the technique, because there is a learning curve, but it's definitely achievable. So the highlighted parts are the pressure points. So you check the lens, you don't get a backup. So that's something that you just have to get used to. And load the lens. So there is a learning curve for that. And if you want to visit the device technology stand, you can practice that. It's a 3.2 millimetre keratome, so this is larger than we're used to. And I do this incision first on a phakic eye as a dry incision. So you can practice that at the time of your cataract surgery. The traditional teaching is 2 paracentesis, but as you progress, now I'm only doing 1. Put the OcuCoat in frugally, so you can see just the snakes of viscoelastic in that image. You have to remove it afterwards, so we're not backfilling as in cataract surgery. Implant the ICL and allow the distal haptics to unfold. And the longer that lens is folded, the longer it will take to unfold. So unless you're somebody that sort of likes to make a cup of tea while the lens is unfolding, I try to work quite as efficiently as I can after I've folded the lens. OcuCoat then goes on top of the lens. Then I make my side ports, position the haptics, and rotate the lens to access after the haptics are positioned underneath the iris. Do your IA, and then do more IA, and then when you think you've done enough, do more again, and check the wounds, intracameral antibiotic. And for these patients, I routinely give Diamox, unlike my cataract patients. Check the IOP at 2 hours. So I just have a surgical video. It is, sorry, can we go back there? I just accidentally went past that, thank you. So, thank you. It is sped up 2 times just for the interest of time. This is me just preparing the injector. We open the lens, put the sponge tip plunger into the lens vial to hydrate, fill the cartridge with OcuCoat and then with BSS, and then load the lens into that cartridge in the loading platform, fishing it out of the vial. And just with a slight twisting motion, you can get the lens to fold in to that loading platform. Then using the lens grasping forceps down the barrel of the cartridge and grasping it and pulling it up into the, closer to the end of the injector, placing the sponge tip plunger into the injector system, and then putting the lens cartridge, clicking it in, and just ensuring that the lens is advancing, and making a dry 3.2 millimetre incision, and then placing lignocaine into the eye that's had just drop anaesthetic, frugal on the OcuCoat, implanting the lens into the anterior chamber, then putting more OcuCoat on top of the ICL, because as I mentioned, quite frugal underneath the lens. You need to make sure you get all of it out. Making a side port incision. As you can see, the eye is still quite soft. I don't put a lot of this viscoelastic in, but in my learning days, I certainly put more in. Positioning the haptics underneath the iris with the lens manipulator, and then rotating it to axis, and just doing lots and lots of IA to ensure all the viscoelastic is out, and then checking the wounds and so on. So I now just want to go on to talk about high myopia and high hyperopia. And the procedure of choice really is a phakic IOL, because if they're not suitable for laser, because the patient can retain accommodation. But if they're not suitable, then you can consider phakic IOL plus laser top-up for the extreme scripts. But sometimes patients aren't suitable because of their anterior chamber depth, so they're not suitable for an ICL at all, and we can consider refractive lens exchange. If you have 10 refractive surgeons in the room, we'll all give 10 different answers. So I'm going to just present some controversies for RLE in the younger patients. So for myopes, they have a high axial length, and this independently increases the risk of surgical complications because we're operating down a well. But independent of this, there's an increased risk of retinal detachment, and because young patients usually don't have PVD, and YAG capsulotomy, they're more prone to developing PCO, and YAG capsulotomy independently is a risk factor for retinal detachment. Lacquer cracks, in addition, can increase the risk of myopic CNV, and this is thought to be due to biochemical environmental changes from intraocular lens surgery, lens removal surgery. And then there are near vision considerations for myopes who are accustomed to having very good near vision, and usually a multifocal lens with an RLE doesn't quite cut it. So for me, I would not be doing an RLE in a young patient who's a high myope. Let's talk about hyperopes. In very short eyes, there's a risk of choroidal effusion and macular edema, and for axial lengths that are very short may need to think about doing scleral windows. But there can be a risk-benefit ratio for eyes with shallow anterior chambers and a risk of angle closure, and I'm not suggesting that all hyperopic patients should have their crystalline lenses removed, but you can consider an IOL, a refractive lens exchange with a multifocal IOL. I certainly do in younger hyperopic patients who might be +9 and hugely debilitated by their Coke bottle glasses. There are huge ranges of sphere and toric lenses available now. So I really would, I do RLEs in hyperopic patients if I think they're suitable. So, you know, RLE with multifocal IOLs is similar to cataract surgery with multifocal IOLs, but the stakes are much higher. So patient selection is important. It has to be meticulous surgery. It's the same as cataract surgery, but you do need to adjust your technique for the very soft nucleus, need a perfect central rexus, must polish the posterior capsule. It's the multifocal lenses, as you would know, are exquisitely sensitive to PCO. You can consider a capsular tension ring, and there is some evidence for increased refractive stability. And if you ever need to remove a lens, then it does make it easier. But the alternative is a dual procedure. So this is a lens correcting for plano in the bag, a monofocal, and a sulcus IOL for multifocality, which makes it much more easily reversible. So here is a young hyperopic patient where I have performed an RLE. There's a lens in the bag. I've performed IA. I've then put viscoelastic into the sulcus and just inserting a plano multifocal IOL, being careful not to rotate that toric monofocal lens in the bag. This was for a patient I was concerned would not tolerate the halos and glares, and I wanted to provide an option that would allow easy reversibility. So for young pre-presbyopic patients, if they're suitable for ICL, then I would perform this. For RLE patients, it's the same as cataract patients. It's easy, but we have we're really spoilt for choice in relation to IOL power cylinder. I do put a capsular tension ring in if I'm concerned about the rotational stability of the lens, and there are some very high toric corrections available on the market now. So because of that, I don't think piggyback lenses really, we're using them for high emmetropia so much, but they can be used for premium add-ons. You always need a friendly and experienced laser surgeon on speed dial. When we're performing refractive surgery operations, the results need to be spot on, and sometimes when we're placing lenses, it's not. So there's my mobile phone number. I'm happy to talk to anybody, and thank you very much. In the interest of time, I'm going to move on and answer any questions later if you have them. I'd like to now introduce Andrea Ang. Dr. Andrea Ang is a corneal and refractive specialist at the Lions Eye Institute, Lions Laser Vision and Royal Perth Hospital, Western Australia. She's the chair of the QEC for RANZCO WA and examiner for RANZCO trainees. She serves on several committees, including the Australasian Society of Cataract and Refractive Surgeons. Dr. Ang graduated with the Gold Medal in Medicine from the University of Western Australia and was awarded a Fulbright scholarship for which she completed a Masters of Public Health at Harvard. Dr. Ang undertook fellowships in corneal and external diseases at the Cincinnati Eye Institute, USA. It's late in the afternoon, I'm sorry. USA and Singapore National Eye Centre. She's the author of textbook chapters and scientific papers on corneal and external diseases, and she presents at national and international conferences. She's also a volunteer with the Myanmar Eye Care Project. Thank you, Andrea.
Thanks so much, Alison. It was my pleasure to work with Donald to be one of his fellows.
Let's talk about, I was assigned this topic, and thank you, Alison, for inviting me. So when the refractive target falls short, laser after cataract surgery to refine the refractive outcome. So, fortunately, in our day and age, we're really lucky to have really great diagnostic equipment, great formula, and amazing lenses, toric lenses, etc. So it's highly expected from patients that they will get a good uncorrected distance visual acuity. But that's not always the case. And for example, this study here done in the NHS found that only 62% of patients were within half a diopter and 89% with one diopter. And looking there at that standard deviation curve, where the solid line is the standard normal population, but the dotted line is really the outcomes. There are patients who definitely end up with some level of refractive surprise. And especially these days when we're putting in more and more of these so-called premium lenses, multifocals, EDOF lenses, they do require a fairly tight refractive outcome for a good result. So why does it happen? Well, there's several reasons. Poor tear film is definitely a major issue and can result in poor biometry, poor preoperative measurements. Certainly, people with irregular corneas, such as keratoconus, irregular astigmatism, pellucid marginal degeneration, patients on either end of the extreme refractive error, especially the hyperopes. Patients have had previous corneal laser surgery, such as LASIK or PRK. In particular, the bane of our lives, radial keratotomy. And also the other thing with formula is that one thing that has improved but isn't always perfect is the effective lens position calculation. So all of these factors can result in refractive error. So when we have a patient with refractive error, some considerations to take into mind is firstly, let's wait for refractive stability. I've certainly seen patients and been referred patients for post-cataract surgery refractive error control where their tear film is just terrible. And when we treat that and we manage that and that settles down after several months, their refraction actually improves to acceptable levels. And certainly post-RK patients, it can take at least 2 to 3 months for the wounds to stabilise and for the refraction to stabilise. Another thing we need to do is definitely consider the binocular situation. So, for example, your first eye, if it ends up with a slight myopic error, that may be deemed unacceptable by the patient, or it may be that they're battling the anisometropia between both eyes, so they're not quite happy with that first eye outcome. So sometimes we actually have to proceed with the second eye and then see how the binocular effect is afterwards. So these are our options, as we know. If somebody is happy in glasses, then the conversation stops there. That's great. We have IOL exchange, piggybacks, and of course laser refractive surgery. So IOL exchange, if there is a problem with the lens in itself, for example, the multifocality, so someone's getting unacceptable glare and halos which they can't neuroadapt to, or loss of contrast, then if there's a problem with the actual lens itself, then really our only option is to exchange that lens. Certainly if there's significant refractive error, which shouldn't happen so much these days, but say, for example, the wrong lens was pulled off the shelf, then that might be a better option is to exchange that lens. And ideally we want to do it sooner when it's a bit safer, when the lens hasn't fibrosed in the capsule, but then we also do want to wait for some refractive stability. So there's a balancing act there. We also have piggyback lenses. Alison's shown us the first Q lens. And certainly for hyperopic outcomes, I might consider that more than laser refractive surgery, or more larger errors that you may not want to do with a laser. But certainly myopic outcomes and smaller, more subtle errors, I think the best option is laser surgery. There's not much literature out there comparing directly the outcomes using different approaches. This is a fairly old study, 2008, but they looked at 57 eyes that either underwent LASIK or lens-based procedure after refractive error after cataract surgery. And it's a 2008 study, so they were using a microkeratome with the LASIK and this three-piece sulcus lens. But they found they got slightly better results with LASIK, 92% within half a diopter versus 81% in the lens group. And they found that people who had a myopic refractive error did better with LASIK, and people with a hyperopic refractive error, there really wasn't much difference between the two groups. So I think overall touch-up laser probably does have better predictability and accuracy than lens exchange or piggyback. Certainly it's an extraocular procedure, so possibly less risk. Like with lens exchange, we all know, we've all done lens exchanges. It can be a heart rate increasing experience. And, you know, piggyback lenses, you always worry a bit down the track, pigment dispersion, glaucoma. Overall, you know, sometimes laser is a better option. Sorry, my slide, I think, cut off on the end there. With laser surgery, obviously the patient needs to be suitable. Certainly for LASIK, usually my minimum corneal thickness is about 500, PRK 480. Regular topography, and ideally, you know, probably no point doing that if they have other vision limiting comorbidities. We do want to wait for total refractive stability and a stable incision. So studies show different things, but generally it's thought to be about 1 to 4 weeks for refractive stability. But practically, I think we usually wait at least about 3 months for both refractive stability, improved tear film, and incision stability as well. And so what do we choose, LASIK or PRK? Generally, you can actually do either, but generally, maybe for younger patients with a better tear film, we might lean more towards LASIK, and maybe the older patients with more dry eyes, and definitely we have concomitant epithelial disease such as epithelial basement membrane dystrophy, then we would prefer to do PRK. I've just shown a diagram here of the corneal innervation. So the reason you get a bit of dryness after LASIK or sometimes PRK postoperatively is because the LASIK flap interrupts the subbasal plexus of corneal innervation, and that can take several months to regenerate. So I'll just finish off with a case. This is a 49-year-old high hyperope who underwent refractive lens exchange. You can see she's got both hyperopia and astigmatism, and we discussed placing an EDOF lens with micromonovision. And these patients, I'm very careful, to counsel for refractive surprise. And these are the biometries, but basically I chose a 31.5 diopter lens, ZXT225. And you can see there is a bit of a spread when you look at the lens star and the different formula. There's a bit of a spread of the different lenses, of the power of the lens. So it's always, a bit, you're always a bit worried in these high hyperopes about the outcome. And certainly she did end up having a myopic surprise. 619 day one, minus 1.75 on week one. So my options with this patient was going to be either a lens exchange or LASIK, but certainly I felt there was going to be more predictability, less risk involved with LASIK. So I waited 3 months. So at month one, she had stabilized a bit more to minus 1.25. At 10 weeks, it was stable. So I like to see repeatability and stability. And then I went ahead and did LASIK. And her result was 6.6 postoperatively with a close to planar outcome. So she was pretty happy. So thank you very much.
Andrea, is that your daughter, Sophie? Yes. Thank you so much, Andrea. I think we'll move on in the interest of time. I'd like to introduce Dr. John Malesh. He's a corneal, cataract and refractive subspecialist and has consultant positions at Liverpool Hospital and Concord Hospital. He's a clinical senior lecturer at University of Sydney and is in private practice in the Sydney CBD and Liverpool. He's the former head of the corneal unit at Sydney Eye Hospital. He has clinical and research interests in keratoconus treatments, including collagen cross-linking, refractive surgical procedures, including relaxed smile, complex cataract surgery, and improving the refractive accuracy of cataract surgery. Thank you, John.
Thank you very much, Alison, for the introduction and for inviting me to this lecture series. I've been asked to talk about some refractive cases, and in general, despite what we've seen today, refractive surgery is mostly pretty safe and predictable, but just like flying a plane, occasionally it can be a bit exciting, and I thought I'd talk about a few exciting cases. So there was Air Transit Flight 236 that was going from Toronto to Lisbon, and at 39,000 feet, midway across the Atlantic, they ran out of fuel and had to make an emergency diversion to the Azores to the Laes Air Base. And they did the longest successful glide of a commercial airliner for 120 kilometres. The glide was so successful, they actually had to do a 360 loop to go down a bit further before they landed. Everybody survived. The pilot was congratulated for his excellent flying skills, but not so much for his ability to read a fuel gauge. So Mrs. DH was a patient that I saw as a second opinion. She underwent SMILE. She was a 41-year-old scientist, lovely lady. The right eye was perfect, underwent SMILE, no problems, was 6'5" on day one. The left eye, however, had a problem. And if I show the video from the original surgery, the laser part of the procedure was fine, but unfortunately the surgeon couldn't find the incision or get into the pocket to be able to remove the lenticule, and basically abandoned the procedure at this point. And so when I saw the patient, she was very anisometropic, with the right eye being planar and the left eye having minus 10 diopters of refractive error. And when I looked at the video, the laser raster pattern looked fine, the side cut looked fine, but the dissection had actually gone underneath the epithelium instead of going into the wound. And so we talked about what to do. We looked at the anterior segment OCT, and you could still see the SMILE lenticule, and she ummed and ahed a little bit about what to do. And 4 months after the surgery, she asked me to remove the lenticule. And I did talk about other options which I thought were perhaps safer, including PRK or maybe doing a LASIK or an ICL, but she really wanted to try and get this lenticule removed. And so we went ahead and did the surgery in the theatre with a dilated pupil, and you could actually fortunately see the edge of the lenticule with the aid of the red reflex. I was thinking I might need to stain the lenticule up, but with a bit of cajoling, you could actually get underneath and above the lenticule, and fortunately it was removed successfully. Because the dissection took a bit of time, it was a little bit of a slower recovery, so she was 624 on day one, but then reasonably rapidly improved and has had a good result. And so she had the longest glide to a successful SMILE landing. So just be aware that whenever we make an incision in the cornea, they never really heal. So whether it's a cataract incision or a LASIK flap or a SMILE lenticule or a corneal transplant, those incisions are always a point of weakness, and you can also, in this case, actually use that to our advantage to remove the lenticule later. Now, I'm going to continue with the tortured premises, but Flight 2012, a classic movie with Denzel Washington, where the catastrophic failure of the mechanics of the plane meant that he had to fly it upside down to slow it down to come into a crash landing, and he basically saved pretty much everybody on the plane apart from 6 people. Unfortunately, it didn't end well for Denzel because he was high on cocaine and drunk at the time. So Mrs. JH has irregular astigmatism, and she basically had pterygium surgery in the right eye in 2020 and ended up with a quite irregular cornea. She underwent cataract surgery with an intraocular lens trying to correct the astigmatism, a T9 lens, so 6 diopter astigmatic lens, but unfortunately after that surgery it was 6/120 unaided and had 8 diopters of refractive astigmatism. And he corrected quite well with that, reasonably well to about 6/18, and he said he would be satisfied with that level of vision, but couldn't wear that kind of correction. When you looked at the eye, there was just a lot of irregular astigmatism and scarring from the pterygium surgery. The IOL axis was 129. When you looked at the IOL master, it suggested that, you can't really see it there, but it suggested there was about 5 diopters of SIL in pretty much the opposite direction to that. And so what do we do? So do we treat the cornea? Do we remove the lens? But the one constant that we knew was that the refraction was actually reasonable with a high astigmatic correction. So I elected to go ahead and put in a sulcus fixated toric intraocular lens with 11 diopters of correction in the IOL plane, which is roughly 8 diopters in the spectacle plane. And we've seen those lenses on the videos before, and he did reasonably well. He was pretty happy. And so sometimes when things are a bit unusual, you have to flip it upside down and use the lens approach for a corneal problem. You may remember this one, Captain Chesley Sullenberger, great name. He ditched in the Hudson River when the bird strike hit his plane just after leaving from a New York airport and successfully landed in the Hudson and saved everybody on board. So Mrs. H.A. has been my patient for a number of years. She's a journalist, lovely lady, had PRK many years ago for a very high correction and had this progressive Saltzmanoid change of both corneas. And whilst her corrected vision was pretty reasonable, the quality of vision was terrible, and she had very high refractive errors with high hypermetropia and astigmatism in both eyes. And finally, she just couldn't put up with the vision anymore. And when you looked at her anterior segment OCT, you could see these large areas of Saltzmanoid kind of change. And so, can you do a laser here? Well, it's going to be rather indiscriminate because it's going to treat both the stroma as well as the scar PK, or do you do the obvious thing, which is to remove the scar tissue? So this is in the operating theatre. You can see both the anterior segment OCT view on the right, and you can see the scar tissue on the left on the operating microscope view. And basically, I just sat there and peeled and picked away at the scar tissue fairly slowly. And by the end of the procedure, which took a while because there was a lot of scar tissue there, and with the help of a little bit of mitomycin C, the cornea became reasonably regular. The scar tissue went right out to the periphery, so there was a little bit of bleeding there, so that wasn't really too much of a problem. And you can see the cornea looked reasonably regular at the end. And after that, she ended up with about 2 diopters or less than 2 diopters of astigmatism and was pretty happy with the result. So sometimes the obvious thing is the right thing. So if the engines stop and there's a river underneath you, just land in the river. And here the obvious thing is to remove the scar tissue. And in my last terrible tortured metaphor, I tell you, I apologise once again, Manifest, a classic Netflix series about a commercial airliner where people took off, had some electrical storm as they took off, and when they landed, it was actually 5 years later, and no one knew what the hell was going on. And I saw this lady, Mrs. M.A., recently for a second opinion. She was actually having increasing myopia as a result of developing cataract, but I was told from her surgeon that first saw her that she had rather unusual corneas. And when you looked at her topographies, her corneas were quite flat with sort of 34, 35 diopter central keratometry. And my first question was, have you had laser before? Oh, no, I haven't. So then I was thinking, cornea plana and other things. And then I looked at her corneas and she had LASIK flaps. And I asked her again, have you had LASIK? Did you ever have laser surgery? No, doctor, never had any laser surgery. She had axial lengths of over 30 millimeters in both eyes, but swore black and blue that she'd never had laser surgery. So just be a little bit aware that sometimes the patients have no idea what's going on, but the slit lamp never lies, just as the people in the Manifest show did. Thank you very much.
Thank you for that very entertaining and interesting talk, John. We've run a little bit of overtime, so thank you for being here, everybody. Thank you to the panel. I just want to do a rapid fire to each member on this panel and ask you what your favourite surgical procedure is and why. Frank, let's start with you.
That last presentation was very interesting because it draws attention to general ophthalmology and looking very carefully beforehand. And just doing exactly what John was doing this is not really my favorite surgical procedure, but it's such a strong lesson. Those things peel off and you can return a cornea to normal. It's not long ago I had a patient who was sent through for an ametropic problem. And I saw the nodules, and having done this before and had a great result, I stripped the membranes and she looked beautiful afterwards, but phoned me because she was very upset because she was now myopic. These peripheral Salzmann's nodules, they were worse when I got the patient, but the initial attending surgeon who did the cataract surgery had disregarded them and done the biometry on the Salzmann's nodules. Now when she was corrected, now she was myopic.
Dr. Malish is
and
right.
needed
The slit lamp
correction.
never
So
lies.
it's a lesson rather than a favourite.
Yes.
But just take those things off, and they come off beautifully easily because you can see the edge when you've de-epithelialized the patient.
Abby, do you have a favourite surgical procedure?
I'm just thinking, thanks, John, I've got to get on a plane in 2 hours. Hard to pick a favourite, but I have to say I really enjoy doing a LASIK. It's very satisfying. It's low risk. Patients are very happy the next day, quick recovery. So, yep.
Professor Town.
I'm with Frank on this one. I love peeling that scab. There is something psychologically satisfying. I totally agree with you.
I think, Abby, I agree. In terms of patient satisfaction, you know, patients, they come back and they say, oh, my vision's amazing. I should have done it years ago. It's life-changing. So when you get a good result from LASIK, it's nice.
I've got to say smile, predictably perhaps, but quick recovery, you almost feel like a surgeon doing it. It tends to have little effect on the ocular surface and the recovery is pretty quick and the patients really like it.
I will go with John on that because that's actually my favourite as
Smile.
well.
Yeah.
It takes away all the LASIK flap issues,
Yep.
which can happen 20 years down the line.
Yeah, I would say LASIK or ICLs, they both have rapid visual recoveries and it's the wow factor that's, you know, instant gratification for the patient and the surgeon. By day one, everything's good. Thank you so much to the audience. Thank you to our panel.